So the next speaker is Professor Marius Geantă. He is the president and co-founder of the Center for Innovation in Medicine, a non-governmental organization based in Bucharest, Romania. He is the trustee and co-chair of the Scientific and Public Health Advisory Committee of FH Europe. And it's a pleasure for us, the ECH Alliance, today to have Marius with us for a few reasons. One, he's a member. So we start to demonstrate in real practical terms what we do on a day-to-day basis, how we can help organizations promote their work. But also, we have over 90 patient groups who are members of the ECH Alliance communities. And this is a very important patient group. And there are some shocking information to actually explain, which Marius will now do. So thank you, Marius.
Hello, everyone. And thank you so much, Bladin, for the introduction, as well, Brian and ECH Alliance. And thank you, Rear Admiral, for your presentation. I will be joining you in the next 20 minutes upstream to actually build a case for cardiovascular health. Indeed, I'm representing today FH Europe Foundation. This stands for Familial Hyperlipidemia Europe Foundation, and we are active in the field of cardiovascular diseases. And I hope to convince you to join us in the transition from cardiovascular diseases to cardiovascular health. And in order, because Bladin mentioned some numbers, we know about cardiovascular diseases that are actually contributed to a large morbidity and mortality worldwide, and more than 75% of the deaths are in the low and middle income countries. And of course, from an economics perspective, the burden is very, very high. 210 billion euros only in Europe is the cost of cardiovascular diseases. It's clear that is not sufficient or is not efficient the way we are actually now thinking and implementing prevention, early detection, and screening for cardiovascular diseases. Is because of the health system design that is more centered on hospitals and diagnosis and treatment. Of course, it's important to be able to diagnose CVD patients and to treat them well, but as well, it's important to pay attention to the prevention and screening and early detection. Are the misconceptions around CVDs. Mainly, the CVDs are perceived like a lifestyle diseases, and I will explain you why this is wrong. Low awareness rate of the people at the populational level on how the cardiovascular health can be promoted and can be preserved. So this is a real need, how to reach a larger audience in order to promote the cardiovascular health. The low interest of the stakeholders in implementing some evidence-based screening and early detection, and I will mention and I will refer to FH screening and LPDTLA testing. The low awareness on the non-modifiable risk factors. This is an issue, and I will refer in a minute, and a very low integration of all cardiovascular health determinants, like social determinants, economic determinants, demographic, environmental, and so on. This is a very classic figure from the public health book showing how complex is our health and how actually different categories of factors influence our health. And you can see that 60% of how our health is actually influenced by social factors, by individual behavior, and in relation with cardiovascular diseases, with the prevention and cardiovascular health. This is an area that is usually neglected, or at least the potential of this area is not there yet. But also very important is this percentage of 22% of factors that are biologic and genetic factors. And from a cardiovascular health or cardiovascular diseases prevention, this is very important, Because we have at least two factors that are genetics. One is related to FH, the other one is related with the Lp(a) that are genetic, are medical, so are not lifestyle factors. They can contribute together with the lifestyle-related factors to an increased risk for cardiovascular health. But these genetic-driven factors require a totally different approach. And I will refer to the FH, familial hypercholesterolemia. And this is the world's most common and non-modifiable CVD risk factor, the most common and non-modifiable risk factor. 1 out of 300 people are suffering, have FH. 50% is the risk of inheriting FH from a parent that has FH. Every minute a child with FH is born, and every day a child with a homozygote form of FH is born. 1 out of these 17 heart attacks is due to the FH. And of course, these heart attacks can be prevented if the FH is diagnosed, and the big problem is that 90% of the FH patients are actually not diagnosed. So I think I convinced you that all these data require an approach to early detection and screening, and there are some types of screening that are very well known, actually were recommended by the WHO more than 25 years ago. A combination of screening models, in fact. Universal pediatric screening can be a model, as well as cascade screening, family screening members of index cases, and opportunistic screening. All of these are important. I mentioned to you that were recognized by WHO more than 25 years ago, but in practice, the implementation is different from a country to another. And that's why 2 years ago, FH Euro Foundation engaged with the Slovenian presidency of the council in order to raise attention and to put the topic of FH pediatric screening on the European agenda. And last year, with the same level of engagement with the Czech presidency of the council was implemented, and you can see the Prague Declaration that at the time is now achieving FH pediatric screening across Europe. And we have been very happy last year to have Vladimir with us at this meeting, and the endorsement of the European Connected Health Alliance for this. And you can see some pictures, how many, you can see that are many organizations endorsing the Prague Declaration, a lot of experts, and this engagement at the highest level of WHO, of our CEO, Magdalena Dacor, who is joining us online. I will refer now to the second genetic factor, risk factor related to cardiovascular diseases, and this is high lipoprotein A. I already said that is genetically. Every person reach the lifetime level of Lp(a) already in early childhood. The Lp(a) level is independent of the risk factors, but if we combine the level of Lp(a) with the other risk factors, lifestyle related, we are in the position to have a better definition of the individual risk for cardiovascular disease. That's why it's so important to go as well for Lp(a) testing. The high levels of Lp(a) affect 1 out of 5 people. That means 1.4 billion people globally. And if one of the parents has elevated Lp(a), there is a greater chance to inherit this risk factor. From all these reasons, we at FH Euro Foundation, we started an initiative, International Lp(a) Initiative, aiming, and the vision is that Lp(a) measurement to become the norm globally, and elevated Lp(a) to be managed efficiently and equitably, and to contribute towards the prevention of premature cardiovascular diseases and related deaths. And we put together a very high-level group of experts, patients, patient representatives, Lp(a) addicts, but as well industry representatives, public health experts, and futurists, health futurists. And I will show you on the next slide that our goals, first goal is to raise awareness, of course, about on Lp(a) and Lp(a) testing. The second goal is to build economic evidence on how to best implement Lp(a) testing in different healthcare sectors. The third, and I really like from the beginning of today's meeting, the discussion about the implementation, with the third goal is on implementation and how this can be done through implementation research. And we are thinking to build some living labs around Lp(a) testing. The fourth goal is on how to best use the data and the digital tools in order to maximize the potential. And the fifth is to put all the initiatives and all these activities in the broader context of the trends, mega trends that intersect healthcare sector. Discussing about data, of course, many people are discussing about this. But when it comes to the screening for FH and for cardiovascular diseases, it's quite easy to find a smart way to screen people using the digital screening, because the data are in the hospital information systems, or could be in the electronic health records or in the registries. And on the right side, you can see a publication coming from a group from Bulgaria, from Eastern Europe, that was able, based on an algorithm, to screen data from actually all the hospitals in the country, in Bulgaria, and being able to early identify people at risk for FH. So I think this is an immediate and a very smart way to go for a different kind of screening. But the next big thing is what is our patients and citizen-generated data. And I think this is a very important topic to be explored, because this data can be medical data, and we are more and more looking to the genomics and other omics data that can be generated by each individual, but as well lifestyle data, behavioral data, socioeconomic data, very important, generated at the individual level, and environmental data. And this is the last topic is very important, because we know that cardiovascular diseases are influenced by the pollution of the physical environment, and now are available different tools that can be used by each of us in order to have a better understanding of the physical environment around us. So if we'll be able to build a model of patient and citizen generated data, and to combine this with the data that are coming from the traditional health systems. So probably one day we'll be in the position to build this virtual twin, able to show us what are the most effective public health interventions, what are the most effective, I don't know, pharmacological intervention, and so on and so forth. Coming back to this slide, I think this is the key for what will come next in the field of cardiovascular diseases and cardiovascular health. We know very well this graph for many years, and we are now in the position actually to transform this graph into data, and to generate data and to integrate data in models that are human-centric. And I explained already what are the types of data that can be integrated. And having this model and having this data model already in place will be more efficient when it comes to education, because the educational intervention will be more targeted at micro level, at meso level, community, and so on, or macro level, but also in terms of building awareness, increasing the citizen participation, and so on. And this model of personalized communication is something that we should have in our mind, and in our project on FH that will start in November this year, we will actually test this model in a real setting, in real life, in few countries in Europe. So I think it's time to discuss about this transition from cardiovascular diseases to cardiovascular health, and probably we should follow some principles. First of all, should be human-centric. In other words, to take into consideration the medical data, but I already mentioned how important are the social data, the individual behavioral data, the spiritual data, and so on. So a really human-centric approach should be in the center of this design. Of course, data-driven should be like a whole of society approach, because now, and I really enjoy your Public Health 4.0, that is about actually engaging the whole society, no matter the topic, what the topic is. We are discussing about cardiovascular health, but can be the same for cancer or other diseases, of course. We should somehow find a new model to complement the top-down approach with a bottom-up approach. And this is, I think, is critical to achieve different results. A key topic is who will lead this, and for sure we need a new model for leadership, and I think this distributed leadership can be a solution. Imagine if we are using the pentahelix model or quadruple helix model with 4 or 5 type of stakeholders. I think this distributed leadership should require a collaboration between at least one representative for each stakeholders group, and to be like a network of people who trust each other first of all. So this model of cardiovascular health should be based on a new model of leadership, and of course it's very important to incorporate innovations coming from the biotech field, genomics, RNA-based therapies, and gene editing, gene therapies, and so on. So these are the pillars we are thinking are important for the cardiovascular health, for moving from cardiovascular diseases to cardiovascular health. But of course, we are very happy to with you to maybe to identify others, then to include them in the model. So this is one of my favorite quotes, saying that the electric light didn't come from the continuous improvement of candles. So, so my and our, as FH Euro Foundation, call to action for you is to start working to a global code for cardiovascular health. I already mentioned the pillars. I think this should be a co-creation process that involve key stakeholders, traditional, but more and more important are the non-traditional stakeholders that should be part of this conversation. Of course, should be evidence-based, but this evidence should come from research, from medical domain, from health sector, but also from digital world, from social sciences, from totally from other areas that, as I already explained, are influencing our cardiovascular health. Of course, frameworks for implementation in real life settings. This is crucial. I'm sure that we all follow the way, let's say, an anti-smoking campaign is implemented, is starting with WHO or other global or European or US organization, then is the engagement at the national level. At the national level, then is the engagement at the local level. And at the end of this very long process, what we are actually see as an implementation, it's a flyer or a poster on the wall at the GP office. And we hope that people will come and see and read the recommendation and immediately will start to apply. So I think this is not the case. That's why I mentioned how important it is to understand the real life settings, environments, the stakeholder mapping and interaction at the local level, but also the citizens' attitude, perception, values, and individual behavior. And of course, this cardiovascular health code should be accompanied by a policy recommendation, but also by a toolbox on how to best engage with the citizens. So I would like to thank you so much for the invitation again. And maybe like a final remark, we are speaking about cardiovascular diseases and cardiovascular health, and in the context of digitalization. And probably it's a good moment to say that cardiologists are familiar with Digitalis, because this is a plant that was used by Hippocrates itself to treat patients with cardiac failure. So, but now with the public health 4.0 and all these new concepts, I think that digitalization in cardiovascular health has different means, and that's why we are here to build on this and to move things to the next level. Thank you.